I'll inject a little lidocaine and hopefully we can get a little more dilation out of this pupil. Lidocaine paralyzes the sphincter muscle, allowing it to dilate a little bit better. And for the main incision, I use a guarded 550 micron metal blade to make a perpendicular groove. And the new HP metal keratome, very sharp, goes to the marker, and then we go more posteriorly for a nice flat incision. Well, there's a little positive pressure in that eye too, isn't there? We'll put Viscoat in, and we'll see that dilates the pupil nicely because the sphincter muscle is paralyzed. We'll put Provisc in. There's the pupil we've wanted to see today. And I use a bent 22 gauge needle to perform the capsulorhexis. We're going to be using Aqualase. This is a 2 to 3 plus nuclear sclerotic cataract. With my softer nuclei, I tend to move to Aqualase because it is more capsule friendly. We've shown in cadaver studies that we could grab onto the posterior capsule with the Aqualase tip, vacuums up to 500 millimeters of mercury without breaking the capsule. We use the Chang cannula for hydrodissection. And we have a little positive pressure in this eye. But we'll be able to deal with it fine. And you'll see the pulses of fluid come out in front of this soft polymer tip and into the nucleus, so I don't actually have to dive the tip into the nucleus to have an effect. That's one of the things that makes this more capsule friendly. As I go down further on the petal, I get more magnitude to the pulses. The center of this nucleus is fairly dense. As I said, this is 2 to 3 plus. We have a nice deep groove now. I'll be able to divide that into 2 halves. Rotate that around. And then I can either stay in sculpt mode and delaminate this into quadrants, as I'm doing here. Or I could go into chop mode and aspirated it. And here we see that with the higher vacuums and low magnitude pulses, this relatively dense nucleus comes out pretty nicely. The flow characteristics of the Aqualase are much like the microtip, because the internal lumen is about the same as the microtip. Now we'll try to chop this half. Bring the vacuum up, a couple bursts of the Aqualase. Divide that nucleus half into quadrants, and then we'll go after each quarter. So we see that things are nice and stable in the anterior chamber. We don't have a lot of pieces flying around. We have good followability. You have no chance of thermal injury to the wound because we don't have a moving metal piece at rapid rate, which causes friction and heat buildup. We have efficient removal of the nucleus. And then we can go to epinucleus setting and remove some of this. This is very soft. It's mostly cortex. And my magnitude there is what? 10? We can even go into position 3 and begin to power wash that a little bit. You see, even though we grab onto the capsule with this soft tip, it's not breaking the capsule. I don't want to be cavalier about it though. Alright. Don't squeeze, leave your eyes open. And then again, keeping in the theme of safety, we're going to use a silicone ionate tip to remove the cortex, much more capsule friendly than a hard metal tip. We'll put some more Provisc into the capsular bag. And we'll be using the Acrosoft Natural. In this instance, it looks like the haptic's straight coming down the cartridge, which is okay. I'll show you how to unroll that lens so it's in the proper position. When the natural lens is rolled into the cartridge, it's very easy to see, but as it unrolls, you might feel a little pressure here. As it unrolls, you'll see that, and flattens out, you'll see that it becomes very difficult to see the yellow hue. So the lens curves from right to left, the haptic curves from right to left, and as the optic comes out, you want to roll the cartridge clockwise so that the haptic comes out, the trailing haptic comes out left to right. And you can see that as it unrolls, the yellow hue is very difficult to see. Natural's become my lens of choice in all of my patients. We also have their clinical studies that show the vision with Acrosoft Natural is comparable to that of the standard Acrosoft with no negative findings. Visual acuity, color perception, and contrast sensitivity were all identical to that of the standard Acrosoft lens. I'm even using this in patients who have the standard Acrosoft in their fellow eye, and they're not noticing any difference between the two eyes. And we put fluid into the incision. It causes the incision to swell and thereby self-seal. Fluid into the side port incision.